Iron is a micronutrient that is essential for life as it's a component of the oxygen transport protein, the hemoglobin. The interaction between iron and oxygen is important in the transport of oxygen by the hemoglobin. In humans, iron exists as a component of the heme, and in the heme ring of a deoxygenated hemoglobin, the iron has one of its coordination sites free, to which molecular oxygen reversibly binds, and this interaction is what helps in iron transport. Iron is also important for the adequate production of the red blood cells. And the red blood cells, they are the most numerous cells of the body, accounting for about 84% of the total body cells, with the rate of production at 200 billions per day or 2.5 millions per second. So daily, we require iron to reach the erythrocyte precursors of the bone marrow, and the amount of iron required for erythropoiesis is between 20 to 25 milligrams. The body also needs to store iron. For males, the total body iron content is about 4 grams, and for females, we have about 3 grams. This body iron content should be kept at a constant, as an overload would be detrimental, as it will facilitate the production of toxic reactive oxygen species, which would also be detrimental to the system, and a deficit of iron would cause anemia. In bloodless medicine and surgery, we are interested in iron replacement therapy because it's geared towards optimizing the hematocrit. And currently, the efforts are in increasing tolerable blood loss and the margin of safety in event of blood loss in surgery and in reducing morbidity and mortality in non-surgical patients. Iron therapy is there with or without the erythropoiesis stimulating agents. So you could see we are dealing with the first pillar of bloodless surgery, optimizing the hematocrit. Let's take a brief history of iron replacement therapy. It entered into the world scene by the 17th century when a man, Thomas Sydenham, proposed the use of oral iron salts for the treatment of chlorosis. This is a disease of adolescent girls and young women, which initially was thought to be a hysterical disease, but later found out to actually be due to iron deficiency. And by the second half of the 19th century, the first iron prepared to be used through the intravenous route came into the world scene. That is the iron saccharide. One would think that there was progress since the 17th century in the use of iron replacement therapy. But this didn't happen because of the problems that were inherent with the traditional compounds. It wasn't until the 19th century whereby improvement in pharmaceutical technologies allowed for production of new iron formulations that minimized these problems that we saw increase in the use of iron replacement therapy. So, who needs iron replacement therapy? One, we have patients who are undergoing renal dialysis. Blood loss in this patient is such that for us to maintain their target hematocrit level, they need iron replacement therapy. Iron replacement therapy is also essential in addressing iron deficiency with or without anemia, in bloodless medicine and surgery, in pregnancy, and in patients with dysfunctional uterine bleeding who are scheduled for hysterectomy. There are 2 types of iron preparations available, the oral and the parenteral. The former speaker talked much on the parenteral, and now we are focusing on the oral. There are 2 sources of that. We have the dietary iron and the oral iron salts. The dietary iron is the iron we get from our diet. It consists only a small fraction of the iron we really require, but it's very important in replacing the daily iron we lose during the traffic in the cells. Daily we would lose about 1 to 2 milligrams of iron, and it's estimated that for a standard European diet, one could get about 10 to 15 milligrams of iron, of which only 10% of that is absorbed. So if 10% is absorbed, we are looking at 1 to 1.5 milligrams. As such, you could see that it could offset these daily iron losses. That is why in secondary prevention of iron deficiency, dietary iron is of great value. And in maternal and child health, its value cannot be overemphasized. However, dietary iron cannot be relied upon as treatment when there is iron deficiency. There are 2 primary forms that dietary iron comes in. We have the heme and the non-heme iron. This non-heme iron is mainly gotten from plant-based foods. The iron in this non-heme is in ferric form. It needs to be reduced at the duodenum by the brush border ferric reductase, with the aid of the duodenal cytochrome B to the divalent ion before it can now be carried by the divalent metal transporter into the enterocyte. As a result of this requirement, it has poor bioavailability, and only about 17% of that is absorbed. Then we have the heme ion. It's mainly gotten from animal-based foods, and the ion is in ferrous form, so it has high bioavailability. About 25% of that is absorbed. We'll see that high-protein diets generally improves ion supplementation. I've tried to put up a table that has some local foods and their iron content. This information is quite helpful for mothers, and also when we have fast-growing children who will require a lot of iron in their diet, we're able to plan the diet properly so that our children can get what they require. Then we move over to the oral iron salts. The oral iron salts are effective means of increasing the hemoglobin levels. They are cheap and they are very safe. They are also important in restoring iron stores. They vary widely in their dosage and the type of formulation they come. Some have iron which is quickly released, others come as a prolonged release. And then they also vary depending on the chemical state the iron they contain is in, whether it's in the ferrous form or in the ferric form. As we've seen, the ferrous form is better absorbed. These are some examples of some oral iron salts we have available. The iron polymaltose complex and the SUCROSOMIAL iron are the more newer types of oral preparations we have. Iron preparations can come in form of tablets or capsules or syrups, elixirs or drops, all aimed at enhancing its appearance and taste, thereby encouraging the compliance by patients. Oral iron salts are suitable and effective for first-line therapy for iron deficiency, and even when there is iron deficiency anemia, and also in obstetric patients. Different oral iron salts, they have similar efficacy and tolerability when you give them at equivalent elemental iron doses. As we progress, we would understand this better. Usually, for an adult, it's recommended that you get up to between 100 to 200 milligrams of elemental iron, and this is better done in 2 to 3 divided doses. Reticulosis is expected to occur after 72 hours you've administered therapeutic doses of oral iron, and the HB levels should rise to about 2 grams per dl after 3 weeks of oral iron therapy. But if after 3 weeks of oral iron therapy and the HB rise is less than 1 gram per dl, this would define iron refractoriness. But for us to conclude that the patient is refractory to oral iron, we'll have to rule out conditions that would cause malabsorption of iron, like the presence of H. pylori infection, celiac disease, or when there is autoimmune gastritis. The divalent form is the most appropriate form of oral iron used in oral iron replacement therapy. We've seen why. The most being used is the ferrous gluconate, the fumarate, and the sulfate. The sulfate is more popular. So, when this iron gets into the system, because of the acidic concentration in the GIT, it enables the ferrous salts to release the iron they contain. This ferrous iron enters into the enterocyte through the help of the divalent metal transporter. The divalent, once it's in the enterocytes, it now needs to move out through the intestinal ferroportin. That's the channel through which iron is exported out of the cells. And it needs to be carried by the transferrin in the plasma. But for this to happen, this ferrous iron need to be oxidized back to the ferric form. And that will be done by the ferric oxidase, which oxidizes it back to the ferric form, and it is now ready to get attached to the transferrin in the plasma. From there, it is now distributed to the target organs, to the liver for storage and spleen also for storage, and then to the bone marrow where erythropoiesis should occur. So we've seen that ferrous salts, they are favored by absorption, is favored largely by a mildly acidic medium. And that is why co-administration of iron with ascorbic acid, as our vitamin C, improves its absorption. And the goal of treatment when we are giving oral iron therapy should be to normalize the hemoglobin and also to replete the iron stores. You don't want to do one and leave the other. This is a table that shows the elemental iron content of some oral iron salts. Like we said earlier, depending on the iron salt you want to use. First, we could see that ferrous sulfate will give us a tablet of 325 milligram, will give us about 20% elemental iron. That is bringing us to like 65 milligram of elemental iron. If you want to use ferrous sulfate, that means if I give my patient this tablet 3 times a day, I would get the recommended 100 to 200 milligram. But if I want to choose ferrous gluconate, I wouldn't want to give it 3 times a day. You need to double the dose, realizing that ferrous gluconate will give you only 10%, which is half of what you get from ferrous sulfate. Provided you take this into consideration and dose your oral iron properly, you will get similar efficacy from irrespective of the oral iron salt you use. Oral iron, however, has its limitation. One, we have compliance issues. The 2 to 3 times dosing, most patients don't comply. A lot of us forget the next dose. I do too. Then we have tolerance issues with iron. The ferrous always cause GIT irritation, and some patients don't tolerate this. Then there are comorbidities that may impact on the absorption of iron. And when this happens, oral iron will lose its efficacy. Then in patients that have chronic renal impairment who are receiving erythropoiesis stimulating agent therapy, oral iron will not give us the desired result. And when there is ongoing iron losses, there exceed absorptive capacity, and when you require rapid iron repletion, oral iron would not be the therapy of choice. Now, to improve on some of the problems inherent with the traditional oral iron salt, another new formulation of iron came into the world scene. It was launched in the 1990s. That is the iron polymaltose complex. It took away the problem of ferrous, which is GIT irritation, and then interluminal chelation and poor bioavailability seen a lot with the ferric salt. The iron in this polymaltose complex is already in the ferric form, but is now chelated, avoiding GIT irritation. It consists mainly of a ferric hydroxide core that is surrounded by polymaltose molecules. This structure is also similar to the physiologically occurring ferritin that we find in the enterocyte. So it's easy for it to enter there. And once it gets in contact with the iron binding site at the surface of the mucosal cells and releases just the required amount of ferric iron. Iron polymaltose complex releases its iron based on a particular feedback mechanism. Its rate of iron release is determined by the availability of the iron binding carrier proteins, that's the transferrin. So you see, with iron polymaltose complex, there will be no free iron, unbound iron available in the system that will cause system overload and as such stimulate hepcidin, or that will lead to blockade of the absorption of iron by blocking of the ferroportin channels. So these are some studies that show the evidence of the iron polymaltose complex superiority over other oral iron salts. And it was seen that for long-term supplementation programs, IPC should be considered and not the traditional oral iron salt. And even in pregnancy, because of the way patients comply to it, it can be taken with food. A lot of pregnant women prefer IPC, and it is good for treatment of iron deficiency anemia during pregnancy. This is a further table comparing IPC with other oral iron salts. We've seen the absorption is active, its efficacy is high. When it comes to system overload, there is none, and it can be taken during or after food. And because the iron in it is in a non-ionic form, it has a delicious taste, unlike the traditional ones that have metallic taste. Then, to further improve on the bioavailability of iron, a newer oral iron has come into the scene, and that is the SUCROSOMIAL iron. This is still under study. It's an innovative oral formulation in which the ferric pyrophosphate is protected by a phospholipid bilayer membrane composed mainly of sunflower lecithin plus a sucroester matrix, and that is what is called the sucrosome. So the iron is enclosed by this sucrosome. Because of the presence of this sucroester matrix, it gets into the intestine intact in that vesicle-like structure and it can cut across through the M cells, the paracellular and the transcellular routes without the need of a specific transporter, from where it enters the lymphatic system, and from there it gets to the liver and other target organs. So because of the way this sucrosomial iron moves, you see that all the iron it contains, it's made bioavailable to the system. So it has been shown to be more efficacious and more tolerable than other oral iron salts. And even in some clinical conditions where absorption of iron was drastically reduced, like the celiac disease, the post-bariatric surgery, anemia in chronic inflammation, then even in iron refractory iron deficiency anemia, studies have shown that sucrosomial iron was found to be effective in these conditions. Further studies has gone ahead to compare the bioavailability of the sucrosomial iron with parenteral iron, and it has been seen that it can be considered as an alternative to IV iron, both for initial and for maintenance treatment in different patient populations, such as the oncohematological patients, in chronic kidney disease patients who are not on dialysis, in post-bariatric surgery patients, even in bleeding patients in internal medicine ward. One thing that's about this group of patients is that usually it was the parenteral iron that was preferred as the treatment of choice for this patient. But studies comparing the bioavailability of parenteral iron with the SI has shown that their HB response is comparable. In oncology, for example, patients who presented with moderate chemotherapy-induced anemia, their performance with oral SI was compared, and it was found out that after receiving oral SI at a dose of 30 mg per day, and another group received the parenteral ferrous gluconate at a dose of 125 mg per week, after 8 weeks of treatment, their HB response was 70% to 71% respectively. You could see the bioavailability was comparable. And then the final HB was greater than 12 grams per dl. And one benefit SI has over the IV iron is that it's better tolerated. Only one person showed GIT toxicity, whereas there were 2 infusion reactions that were witnessed with the ferrous gluconate. Similar studies were repeated in nephrology and in gastroenterology with patients of post-bariatric surgery. It was compared with the IV iron sucrose, and it was also similar results were repeated, showing that SI is comparable to the iron gotten from the intravenous routes. Then another benefit oral SI has over parenteral iron is that it's cost effective, as it's cheaper than iron from parenteral routes. It was also observed that pre-operative iron supplementation with sucrosomial iron given 30 mg per day for 3 to 4 weeks helped to reduce the length of hospital stay for patients from 6.5 days to 4 days, and the number of transfused units was also reduced from 7 to as low as 0. Another important benefit of SI is that when it was tested in mice, it showed minor or no significant increase in the liver hepcidin, and we've seen that hepcidin affects iron, greatly regulates iron homeostasis. Anything that will increase the liver hepcidin mRNA or the serum hepcidin levels would affect the absorption of iron. There are also promising results in the use of SI in relation to preventing anemia in pregnancy. Despite all the good results that have been gotten from the use of sucrosomial iron, in order to confirm these promising results, we will still need to carry out appropriately sized randomized control trials. Some of the trials were done with few number of patients, and these trials also need to be done in different clinical settings to see if these results can be reproduced. Then we can't talk about oral iron therapy without mentioning some of the adjuncts of oral iron. We have the vitamin B12, the folate. They are all very important, as the vitamin B12 is needed in the production of the red blood cells, and folate plays an essential part in hemoglobin production. So when we are giving oral therapy and we add these adjuncts to them, they bring about a synergistic response in the hemoglobin maximization regimen. Vitamin A also is quite important, as it helps the body to absorb and use iron. Foods rich in vitamin A and beta-carotene, such as the carrots, our cantaloupes, mangoes, are quite helpful. Zinc is also another micronutrient that is beneficial in the daily absorption of iron, although it may not be so useful in weeks. But it has been found that deficiency of zinc can aggravate iron deficiency anemia, since it's a cofactor of several enzymes that are involved in iron metabolism. Now, how do we dose iron? To be able to dose iron properly, you need to calculate the patient's total body iron deficit. You now determine which type of preparation you want to use and now decide how many doses of this desired preparation would be enough to offset the deficit. The cumulative dose for iron repletion is usually based on the patient's HB and body weight and should not be exceeded. We have two methods of determining the cumulative dose, the Ganzoni formula and the simplified method. That is the Ganzoni formula. The total body iron deficit is calculated as a product of the body weight and the difference between the target HB and the actual HB in gram per liters of the patient, and also multiplied by the factor 0.24 plus the iron depot. Usually for patients who weigh above 35 kg, the iron depot is about 500 milligram, and patient weighing less than 35 kg, that will be calculated by 15 milligram per body weight. Then, this is an example of how the Ganzoni formula can be used to calculate iron deficit in a 70 kg female. The simplified method involves estimating the cumulative amount of iron required to replete iron body stores using the table below. However, caution should be applied when you want to use the simplified method, as it was tried only just on a single study, and the patients that were used had inflammatory bowel disease. Then, how do we administer iron? Oral iron, the traditional oral iron salts, are better given in 2 to 3 divided doses on empty stomach. You can take them with a full glass of water or juice. For children, they can take half glass of water. But this does not apply to the iron polymaltose complex, as we've seen, and also the sucrosomial iron. You may want to eat to lessen the possibility of stomach upset. If you're giving liquid formulations, they have to be diluted with water or juice so that they will not cause tooth staining, or you use droppers to ingest them. The dosing and administration of iron is largely guided by our understanding the hepcidin physiology. We've seen that hepcidin critically reduces systemic iron homeostasis by blocking the ferroportin, that is the channel for exporting iron out of the cells. What happens with the traditional oral iron salt is that they release the whole iron into the enterocytes, which is carried in by the divalent metal transporter. And then this ferroportin opens up for the ferrous ion to come out. When they come out, they are oxidized by the ferric oxidase. But if the transferrin, that is the carrier proteins, are not available, and if enough is not there to mop up the whole ferrous ion that is released, the ion stays in the system and causes a high concentration of serum iron. And this upregulates hepcidin, which now blocks the ferroportin channels without considering whether iron stores have been repleted, and even there could still be anemia when hepcidin does this. So that is why when you're giving traditional oral iron salt, you have to space it enough to allow hepcidin levels to return to normal levels that will allow for further absorption. But we'll see that these problems will not occur when you're using the iron polymaltose complex or the sucrosomial iron. Then, as pharmacists, we're interested in what iron we interact with so that we can better advise our patients properly. We have two of this kind of interactions. We have food and drugs. The food that interfere with iron absorption are tea and coffee. In tea, we have the tannins, the oxalates that chelate iron. And in coffee too, we have caffeine. This caffeine inhibits the absorption of iron. Milk has calcium, grapes contain tannins, the pasta products, they contain gluten, the brown rice, our wheat products, they contain phytates of phytic acid, and our peanuts, they contain oxalic acid. And these things will chelate iron and affect its absorption. Whereas fruits such as citrus fruits, the dark green leafy vegetables, bell peppers, melons, strawberries, all these have high content of vitamin C and they improve the absorption of iron. There are drugs that also interact with iron absorption. We have our antacid, they chelate iron and affect its absorption. Then the H2 antagonists, these antagonists, they suppress gastric acid secretion, and this would have an impact on the absorption of iron, which is encouraged by an acidic medium. Then we have the proton pump inhibitors like the omeprazoles. They cause upward regulation of hepcidin, and this now affects the absorption of oral iron. Then ascorbic acid increases the absorption of that. We've seen why. And then when our patients are on these drugs mentioned below, like the Sevdina, the dolutegravir, we want to be concerned because iron decreases their blood concentration. So we want to check to know when we would need to titrate the value of such products. Are there complications with oral iron? Yes, we have the mild to moderate side effects, and the serious to severe side effects are mainly seen with intravenous preparations. The mild to moderate side effects are these: constipation, stomach pain, nausea, vomiting, headaches, and sometimes cough. And then the serious to severe side effects mainly seen with intravenous preparation. The only one that concerns us with oral iron preparation is that of the change in the gut microbiome, where it decreases the biofidal bacteria and the lactobacilli and increases the enterobacteria, including the enteropathogenic E. coli strains, which is quite discomforting. So what are we saying in summary? We've seen that iron is indispensable to life. And from our diet, we can absorb enough iron that could obligate the daily losses of iron in the trafficking that we find in the cells, but it cannot be used for treatment. And when we are giving oral iron therapy, our aim should be to target the hematocrit level and also to replete the iron stores. We don't want to do one and leave the other. Oral iron, despite its ups and downs, is still very effective when there is no urgency and when patients can tolerate it. And newer oral iron preparations like the iron polymaltose complex offers a lot of benefits ahead of other traditional iron salt. In fact, in our hospital, we've used this a lot. And in circumstances when there is significant ongoing iron losses, we don't want to rely on oral iron. We would need to move over to the intravenous iron therapy so as to offset the iron deficit that is needed for erythropoiesis. But although intravenous iron therapy plays a big role in bloodless medicine and surgery program, there are now newer oral iron preparations like the SUCROSOMIAL iron, which can now compete effectively with it, give equal results with less adverse effects and more cost effective.